Can you see my slides? No. Wala. Can you see my slides now? No.
Kita na po po.
Pero I cannot see myself, right? If I share slides. Tama ba?
Yes, yes.
Ang problem sa Google. Anyway, so let's start because we have two topics for today. First is your hypertensive diseases in pregnancy, and the second topic will be multifetal pregnancy. So our objectives, to be able to define, discuss hypertensive complications in pregnancy, to include the risk factors, to be able also to differentiate the different types of hypertensive complications, and to know the diagnostic and therapeutic management in hypertension in pregnancy, and to be able to know complications of hypertension in pregnancy. Hypertension in pregnancy are all pregnancy diseases complicated 5 to 10% of pregnancies, like preeclampsia, 3% of all pregnancies. The etiology is multifactorial, so there is no one cause for preeclampsia. For the risk factors, we have your maternal personal risk factors, maternal medical factors, and placental risk factors. So for the risk factors, we have maternal personal risk factors. One maternal personal risk factors.
Sorry, I'm not able to make a phone call at this time, but you can ask me to place a FaceTime call.
Sorry for that. Napindot ko yung aking Siri. So, risk factors, we have maternal risk factors like premiparity, we have the one, premipaternity, and then history of preeclampsia, 14% with a recurrence rate. You also have obesity and family history of preeclampsia. For ethnicity, we have the black race. They have twice the risk than the white women. For maternal age, it occurs more than 40 years old and occurs twice the risk. And then there's also your smoking. That's why you have to ask in your history and physical examination regarding smoking. And other unresolved factors like interpregnancy intervals, which are short, or intervals of more than 10 years. Then we also have the previous miscarriage and abortions and environmental risk factors. For your maternal medical risk factors, we have the presence of diabetes mellitus. Okay, so you always have to look if there is diabetes occurring also with your hypertension, or if there's hypertension, you also have to rule out any presence of diabetes mellitus. And then the presence of antiphospholipid syndrome, presence of systemic lupus erythematosus, renal disease, maternal infection, and increased risk with UTI and periodontal diseases. So, during the prenatal period or antenatal period, we have to ask your patients to go to a dentist for checking any dental caries, because that would also increase the risk of having hypertension. The third class for your risk factor are your placental or placental risk factors, where one is multiple pregnancies. This will be discussed in detail on the next lecture. 13% occurs in singletons and 5 to 6% in twin pregnancies. So for molar pregnancy, you can see a very early onset preeclampsia usually. So if there is hypertension with severe vomiting, then you should suspect for a presence of molar pregnancy. So etiology, as I've mentioned, is multifactorial. It is a culmination of factors that likely involve a number of maternal, placental, and fetal factors. So they can be combined, okay, or mixed match. So for the factors, first is placental implantation with abnormal trophoblastic invasion of uterine vessels. Normally, we have there should be placental invasion. So we'll explain that a little while. And then immunological maladaptive tolerance between maternal, paternal, or placental and fetal tissues. Third is maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy, and genetic factors including inherited, predisposing genes as well as epigenetic influences. So we have your shallow trophoblast. This is the algorithm of your occurrence of preeclampsia in the blood vessel. So there is presence of shallow cytotrophoblast invasion, causing high resistance vasculature, causing placental hypoperfusion, which increases your factors like your PIGF, growth factors, your split 1 or split 2, okay, and causing placental ischemia. And further ischemia would again increase these factors, okay, causing your intrauterine growth, restriction, oligohydramnios, and possible fetal demise in the course of preeclampsia if it is not controlled. Okay, so these factors would cause androgenic imbalance, endothelial dysfunction, causing hypertension, proteinuria, which also could affect other organ systems. So this picture would show that this is the normal non-pregnancy blood vessel or spiral vessels in the endometrium. Okay, normally it looks like this. So when there is during normal pregnancy, okay, with the placenta present, there should be a normal invasion of your cytotrophoblast, okay, and which causes vasodilatation, okay, which would prevent presence of hypertension. But in preeclampsia, there is shallow trophoblastic invasion causing vasoconstriction here. Compared to there, this is a vessel which is dilated. This one is vasoconstrict. So this would entail an increase in your factors, as I mentioned a while ago, which would again affect your androgenic factors, which would affect vasodilatation, or which cause vasoconstriction, and then eventually would lead to preeclampsia. So these are again another algorithm for your risk factors. Okay, in a nutshell, so you have there first pregnancy, history of hypertension, diabetes, obesity, autoimmune diseases, age extremes, okay, multiple gestations, and other genetic factors. These are your multifactorial. It was mentioned a while ago. It's the disease is multifactorial. So either okay of these can occur at once. With the abnormality of cytotrophoblast invasion, so there's inadequate cytotrophoblastic invasion of the maternal spiral arteries, causing uteroplacental malperfusion, thus leading to placental ischemia. Okay. Again, leading to increase in your different factors like your PGI2, placental cytokines, interleukin 6, endothelin, endothelin in the blood, okay, which again further causing generalized endothelial cell injury and causing reduced renal plasma flow, increased vascular resistance, increased arterial pressure, and enhanced pressure response. Again, would lead to hypertension, proteinuria, edema, okay, and then preeclampsia. Okay. When there's preeclampsia, you could have pathology or abnormality in the placenta, the fetus, and in the mother. For the placental pathology, you could have venous hypoplasia, atherosclerosis, infarcts, abruptio placenta, small placenta. Okay. So in the fetus, you could see a small baby or intrauterine growth restricted baby, SGA baby, okay, and hypoxia. Also, there is an increase in morbidity and mortality. In the mother, you could also have increased morbidity and mortality. you could end up having DIC. Okay, I think we already discussed that last time. Your coagulation consumption, okay, your DIC, and then HELP syndrome. We all know the meaning of that one. We discussed also that last time. Then eclampsia. We will go into further details with that later. And renal, hepatic, and cerebral disease. So again, it's a multi-system disease. It could affect the heart, the liver, the kidneys, and the arteries. And what we don't want is it could also affect the brain, which could cause seizures and cerebrovascular accidents, and might cause stroke, and eventually the patient may die. So hypertension in pregnancy, okay, you have different types of hypertension in pregnancy. Okay, includes the following. You have your gestational hypertension, plain preeclampsia, okay, there's eclampsia, there's chronic hypertension, there's also preeclampsia with superimposed on chronic hypertension. Okay, so these are the types of diagnosis you might have in a patient. It's not suffice that you know that the patient is hypertensive. You have to know how to differentiate each of one of them. Okay? So we go one by one. For chronic hypertension in pregnancy, okay, either there is already a history of hypertension preceding the pregnancy, with or without hypertensive medication. So it means to say the patient is not yet pregnant, she's already hypertensive, a known hypertensive. So you can have that detail during your history and PE, or when you get your history, if she ever had hypertension in the past. Okay, so the medical history. There's a blood pressure more than 140 over 90, although our new medical classification, or your cutoff for hypertension is 130 over 90. The cutoff for obstetrics of 140 over 90 has not yet changed. Okay, so it's still we follow the 140 over 90 cutoff. So this one, it occurs prior to 20 weeks age of gestation. Okay? So if the hypertension occurred at around 10 weeks, you still call that chronic hypertension in pregnancy. Okay? So what is gestational hypertension compared to your chronic hypertension? Okay? So there is at least sustained 2 occasions of elevated blood pressure 6 hours apart. Okay? More than 140 over 90 blood pressure after the 20 weeks age of gestation. So ito, after. Okay? Before, if it's before the 20 weeks age of gestation, it is called chronic hypertensive disease or chronic hypertension. So without, this could occur without, okay, you have to take note, without proteinuria or other signs of preeclampsia or a prior history of hypertension. Okay? Once you have this with proteinuria, it already becomes your preeclampsia. So preeclampsia without severe preeclampsia can be subdivided into two. You have the preeclampsia without severe features, or previously called the mild preeclampsia, and the terminology now is preeclampsia without severe features. Those with severe features are called preeclampsia with severe features, okay? Previously classified as your severe preeclampsia. So nowadays, we don't anymore call them preeclampsia severe or preeclampsia mild. We use this terminology, preeclampsia without severe features or preeclampsia with severe features. So we go first to your preeclampsia without severe features. So it is hypertension sustained at least twice, 6 hours apart, but not more than 7 days apart, with blood pressure and proteinuria. With blood pressure and proteinuria occurring more than 300 milligrams in 24 hours in a woman, and without prior proteinuria, and after 20 weeks of gestation in a woman with previously normal blood pressure. Okay? Class, just to check, do you still hear me?
Yes,
Yes po,
Okay.
yes po.
So sorry with that. Okay. Just inform me if I am I don't have my slides on or you don't hear me. Okay. So for the preeclampsia with severe features comparing to your severe preeclampsia, okay, so preeclampsia with any one of the following. Conditions, we have a blood pressure more than 160/90, and then 2 occasions 4 hours apart. Okay. And then thrombocytopenia, platelet of 100,000 millimeters, and or evidence of microangiopathic hemolytic anemia, increased hepatic transaminases, AST and or ALT twice the upper limit, new onset or worsening renal insufficiency with a creatinine of 1.5 milligrams per DL or doubling serum creatinine. And then persistent headache or cerebrovascular disturbances. So anytime your patient is already complaining with a headache or cerebrovascular disturbances like blurring of vision, okay, or vomiting, okay, persistent epigastric pain or right upper quadrant pain, and then there's also pulmonary edema or cyanosis, we already classify that preeclampsia with severe features. Okay. So compare that. So we already have preeclampsia without severe features, preeclampsia with severe features. What is preeclampsia or superimposed preeclampsia? Okay. As the term implies, superimposed, it means there was already a pre-existing hypertension. So that is your chronic hypertension, and then the patient still develops preeclampsia. So that is your chronic hypertensive disease with superimposed preeclampsia. So what is the definition of the superimposed preeclampsia? You have one or more of the following criteria: new onset proteinuria of more than 300 milligrams in 24 hours without prior proteinuria, and after 20 weeks in a woman with chronic hypertension, or sudden increase in proteinuria in a woman with known proteinuria before or early in pregnancy. So this one, before the 20th week, she has hypertension, and then after the 20th week, she develops preeclampsia. Okay. Actually, when a patient previously have hypertension already and develops preeclampsia, we already consider that as a preeclampsia with severe features or a severe type of preeclampsia. So it is superimposed. So a sudden increase in hypertension, previously well controlled, or escalation of antihypertensive medication to control BP. Okay? Shows she already have a previous medication, okay, but still, despite all those medication, while the age of gestation is progressing or uh, forwarding, okay, so you have to add some more of the medication. So example, previously she's taking metildopa every 3 times a day. It becomes 2 tablets 3 times a day. Then it becomes every 6 hours, etc., etc. So we go to the next. So the superimposed preeclampsia with severe features, as I mentioned again. So you already have a severe range of blood pressure of 160, 100 or more. Okay, despite escalation of an antihypertensive medication, there's note of a platelet count of 100,000, less than 100,000, and then increased hepatic transaminases, usually 2 times the upper limit, new onset or worsening renal insufficiency with a creatinine more than 1.1 milligrams per DL or doubling of serum creatinine. You also have pulmonary edema and there is persistent neurological symptom, headache, visual changes. Okay. So we go to the management of preeclampsia less than 34 weeks. So observe in the labor and delivery suite for 24 to 48 hours. You should give magnesium sulfate for 24 hours to prevent what? Seizures. So antihypertensives if indicated, but usually we have to give them. And ultrasonography, okay, to note for the confirm for the age of gestation, the biophysical scoring, okay, the amniotic fluid, and monitoring of your fetal heart tone and symptoms and certain laboratory tests, which would help you, okay, if to note if there is a worsening maternal condition. So any of the following could be present: eclampsia, pulmonary edema, DIC, suspected abruptio placenta, non-reassuring fetal status, okay, or labor rupture of membranes more than 34 weeks. So for these patients, if you have already this one, you have to give your mag sulfate, dexamethasone if needed, okay, and then already deliver the baby, okay, so as not to have a worsening maternal condition. So as you see, the cutoff is 34 weeks. There is no reason to prolong pregnancy if the hypertension is already the severe type or there is already preeclampsia severe. Okay, so give steroids if less than 34 weeks. Okay. However, if it's less than 24 weeks, okay, is hardly viable. Okay, you still also have to terminate the pregnancy already. But if there is a way where we can prolong that pregnancy, at least we have to meet the batting average of your NICU. Okay, so if you have a good nursery ICU, you could deliver that baby at least 32 weeks. Okay, but for our institution, we have to meet at least 32 to 34 weeks. So for those for between 24 to 33 weeks and 6 days, give magsulfate for 24 hours. Give also your antihypertensives. Still your steroids, dexamethasone or betamethasone. Daily evaluation of your maternal fetal condition. Delivery if with indications. Again, no reason to prolong pregnancy if preeclampsia severe at 34 weeks. Okay, what do? The ER, we have to monitor your vital signs, monitor for the fluid intake, monitor for the urine output, okay, monitor for symptoms of headache, visual changes, or retrosternal pain, chest pain, okay, uh, nausea and vomiting, epigastric pain, okay, difficulty of breathing, okay, or shortness of breath every 8 hours. Okay. And if you see this, okay, these are already warning signs. Okay, I think you already have to decide for a cesarean section if you cannot deliver immediately. Okay, so as not to cause any cerebrovascular accident. So you also have to note for the contractions, the rupture of membranes, abdominal plane, or bleeding every 8 hours. Then laboratory testing, which includes CBC, okay, platelet count, liver enzymes, serum creatinine daily or every other day if the patient is stable. So fetal assessment, we have to ask the mother for tick counting, and we have to do also our non-stress test daily. Biophysical scoring should be done. Ultrasound with biophysical scoring twice a week. Serial fetal growth monitored every 2 to 3 weeks. Then you have to do a request for a Doppler ultrasound, particularly on the umbilical artery, to note if there is fetal growth restriction. Okay. So next is your we have to define what is HELP syndrome. Okay. So it is a dreaded complication of your hypertensive diseases, as you already know that. Hemolysis, okay, and then there is elevated liver enzymes, your EL, And then there is low platelet count for the LP. That is why it is called HELP syndrome. Okay? So hemolysis, there's abnormal peripheral smear in addition to either serum LDH, which would denote rupture of your RBC, more than 600 international units per liter, or a total of bilirubin of more than or equal to 1.2 milligrams per deciliter. So elevated enzymes, liver enzymes, as evidenced by an AST or ALT, or your SGOT, SGPT, twice the upper limit. And then platelets start to decrease to less than 100 per milliliter square. So for the classification, I think, I don't know if you're the group whom I gave the assignment. So this is the classification of your HELP syndrome with the Mississippi classification. Class 1 HELP syndrome, there's severe thrombocytopenia with platelet count of less than 50,000 with an LDH elevated and your liver enzymes also elevated. Class 2 type is the moderate type. There's moderate thrombocytopenia. Platelet is between 50 to 100 with elevated LDH and elevated liver enzymes. And class 3, HELP syndrome, you have mild thrombocytopenia, platelet between 100 but less than 150, and again, still you have your elevated liver enzymes and your ALT and your elevated LDH. So after that, we go already to eclampsia, another type of your hypertensive complication. Okay, so eclampsia is presence of seizure with preeclampsia. So preeclampsia plus seizure is eclampsia. So seizures are characterized to be grand mal in character, and there could be also presence of HELP syndrome, but not always. Okay? What is the criteria? The presence of seizure and preeclampsia plus minus or your HELP syndrome. So eclampsia occurs 2 to 3 cases per 10,000 births in developed countries, while in countries like ours in the third world, we have higher cases, between 16 to 69 cases per 10,000 births. Okay? It occurs antepartum or during prenatal time, 40 to 50%. It can occur during delivery at 20 to 35%, and can occur also after delivery, 10 to 40%. During late postpartum, it is rare, but still can occur. Okay, more than 48 hours, but less than 4 weeks after. But we still get to see some patients who have eclampsia even after 6 weeks, or at 6 weeks age of gestation. Okay, those are more the later ones. Okay? Especially if they're not taking their medications at home and they are previously diagnosed having already chronic hypertension. So the basic objectives in management of eclampsia is maternal support of the vital functions, of course your ABCs, airway, breathing, circulation, control of convulsions and prevention of recurring convulsions. You have to correct maternal hypoxemia or acidemia, oxygenation, okay, proper positioning, control of severe hypertension to safe range. You have to lower that, and initiate process of delivery, and also postpartum surveillance. Management is hospitalization with control of convulsions and prevention of recurrent convulsions. We have to give your parenteral sulfate, which is the drug of choice to control convulsions in eclampsia. Okay? But if you have sudden seizure, okay, so you have active seizure, the best drug to give is your diazepam. Okay? But for control or prevention of convulsions to occur next time, you have to use the sulfate. So how do we give magnesium sulfate? A loading dose of 4 grams is very slow IV. It's given over 5 to 10 minutes. Okay. And then after that, we give our 10 grams deep IM intramuscular injection. 5 on alternate botox. So 5 in each botox every 4 hours, okay, until 24 hours after delivery. Okay, so 4 grams initially IV with 10 grams IM, and then after 4 hours we give 5 alternate botox, okay, until 24 hours after delivery. Okay, so loading dose of 4 grams, or another way to give it is a loading dose of 4 grams IV followed by IV infusion of mag sulfate at a rate of 2 grams per hour. So in 1 liter of IV fluid, we have to incorporate your magnesium sulfate. So 2 grams per hour. Okay, we have to put your 10 grams. Okay, if it's you give 20 grams, you give 100 cc per hour through Soluset, so as not to fast trip the IV fluid. So incorporate 20 grams of MOX sulfate or 4 times 10 ml ampoules of 50% MOX sulfate to 1 liter of D5 water or D5NM, and infuse at a rate of 100 ml per hour. That's already 2 grams per hour via infusion pump or Soluset. And then the rate of the drip may be reduced to 1 gram per hour after 24 hours. So before we give magnesium sulfate, you have to be sure you have to check the following, okay? So we have precautions. Once there is abnormality of the following, the 4 criteria, we cannot give your mag sulfate. Okay? So first, you have to check the urine output. It should be 30 ml or 100 ml for the past 4 hours. So 30 ml per hour or 100 ml for the past 4 hours. So we have to insert our Foley catheter, IFC. There should be presence of patellar reflex with DTR of +2. Okay? And the respiratory rate should not be less than 12 cycles per minute. And be sure that you have presence of intravenous IV calcium gluconate at bedside. Okay? To give as an emergency medication if ever there are signs of magnesium toxicity. Okay? So if available, serum magnesium levels may be taken at a certain intervals to monitor mag sulfate toxicity. So memorize, please. Urine output of 30 cc per hour, presence of DTR +2, and RR not less than 12. Okay? So you should know this by heart as a clerk, as an intern. Okay. As those going to the ward, this is a must to memorize. So mag sulfate levels, if there is a level of 4 to 7 milliequivalents, okay, it prevents eclamptic convulsions. However, in higher levels like 8 to 10, there is the start of disappearance of your patellar reflex. So this is a warning for impending toxicity. If there is already 12 milliequivalents level, there is already respiratory depression followed by respiratory and cardiac paralysis and arrest. Okay? So you could die also of giving your mag sulfate level, mag sulfate. Okay? So you have to know properly how to give it and infuse it properly. Okay? We cannot give it on a very fast rate or else there could be complications. So other drugs used, as I mentioned a while ago, diazepam is usually used to control active seizures. So loading dose is 10 milligrams slow IV for 2 minutes. And then you can give maintenance 40 milligrams in 500 ml NSS for the first 24 hours. However, it is better to give your mag sulfate instead of diazepam if you want to prevent already seizures, okay, in pregnancy. Another drug which can be given is your phenytoin for prevention also of convulsions and may be used with diazepam. It could be given 1 gram slow IV over 20 minutes, then 100 milligrams every 6 hours for the next 24 hours. So, antihypertensives, your hydralazine is the drug of choice. The IV is readily available. However, the tablet form is already out in the market, but I have the chance to see when I was a resident the tablet form of the hydralazine. However, it is already removed. Okay, it is already out of the market. So you could give it intravenously, 5 to 10 milligrams at a interval of 20 to 30 minutes until the desired BP is reached. However, you should not exceed 40 milligrams in a day. Okay, so if it exceeds already 40 milligrams a day, it means the blood pressure is uncontrollable. Okay, so you have to deliver the baby and you have to decide for an immediate cesarean section if uh, this happens. So clonidine, next recommended. Okay. So nifedipine can also be given orally, okay, but you cannot give it sublingually. Okay, it's a we cannot give it sublingually, not like in non-pregnant patient where we can give it sublingually. We only give it orally. Okay, 10 to 20 milligrams. Okay, a day. Okay, we can also increase it, okay, to at least 20 milligrams every 6 to 8 hours. Okay, as you all know, nifedipine is not only an antihypertensive drug. We also use it, okay, in our management of preterm labor. Okay? So nifedipine is a new drug. Okay? Actually, it's not really new. We have been using it for quite some time for also the control of preterm labor. So labetalol is also an IV form where you can give 10 to 20 milligrams initial dose. However, you have to be careful not to give it with those with asthma or those with congestive heart failure. So nicardipine, it is given initial rate of 5 milligrams per hour and titrate 15 until there's reduction of 15% reduction of your mean arterial pressure. So it is a must that you know how to compute for your mean arterial pressure. Okay? Uh, we've been teaching you in the ward how to compute that. Okay? Your diastolic, 2 times diastolic divided by your 2 diastolic plus systolic divided by 3 is your map. Okay? However, the problem with the cardipine is that you have to replace your IV lines every 6 to 8 hours. It becomes can be clogged, and then it can also cause renal shutdown. So you have to be very careful in using it. So we only give the cardipine if we really cannot control the blood pressure post-operatively. Okay, we cannot control it only with hydralazine. Then we have to resort with a continuous drip of nicardipine. Okay, with the help of our friendly internists. So delivery after control of convulsions. Okay, so you have to do labor induction if you can. Okay, still do labor induction for an assisted vaginal delivery. Okay, so if the pregnancy is term or near term, and there's only one um, episode of convulsion, and then the vital signs are controlled and the hypertension is controlled, then maybe we can um, try trial of labor for labor induction. For those less than 34 weeks, close supervision to allow fetal lung maturity. Cesarean delivery is done when vaginal delivery does not appear to be easy and imminent. Like example, if the patient already had twice seizure and the cervix is hard, firm, closed. Okay. So you cannot do cesarean, you cannot do vaginal delivery immediately, then you do your cesarean delivery. If there's worsening maternal condition, then do cesarean delivery. So again, if there's also failure of progress of labor after induction, do cesarean delivery. And if there is fetal compromise, like there is non-reassuring fetal status when you monitor the baby through your CTG, cardiac topography, or your non-stress test, or a very low biophysical scoring, or you have signs of reverse flow, in absent to reverse flow in your Doppler velocimetry studies, then we have to resort to cesarean delivery. Okay? So for comatose patients, okay, which we don't want to happen, okay, especially those who have cerebrovascular accidents after seizure, okay, neurologic evaluation is necessary. We have to refer them to the internal medicine department. We have to request also for CT scan or MRI if available. Okay, especially CT scan is not done when the baby is not yet delivered. What we prefer is your MRI because CT scan also emits radiation. So this is just a clinical study of eclampsia, okay, in India. So they noted that the major complications of eclampsia are the following. Okay, so you have a lot. You have placental abruption, DIC, have syndrome, acute renal failure, so aspiration pneumonia, cerebral hemorrhage, and cardiopulmonary arrest. Okay, pulmonary edema. Okay, you could also have eclampsia with postpartum psychosis, which is a little bit high. Hepatorenal failure, hypoxic encephalopathy, okay, abruptio placenta and septicemia, DIC, aspiration pneumonia, and there is also need for ventilation support. Okay, so it's a dreaded complication. Eclampsia is a dreaded complication. We don't want our patients to go into eclampsia. So as early as possible, you already have to identify the patient if she is high risk of having hypertension during the course of her pregnancy, so as not to go into eclampsia later. So again, prevention, early detection and diagnosis of preeclampsia. So adequate blood pressure control with medications, adequate antenatal or prenatal checkups, okay, either in the rural health unit, midwife, okay, or a nurse, or the private obstetrician, or OB, or in a government setting, whatever. Or they could also, for this time, since it's a pandemic, they have to avail for telemedicine, okay, or um, through your virtual platforms, okay, your EPA checkup. In Region 1, we have our EPA checkup where they can have their prenatal checkups through the internet, okay, or through the use of your computer. Okay? So, but however, we have to ask them their cooperation in also monitoring their baby. So proper and early referrals. Okay, so you as clinicians later must be you will be the first liners. Okay, once you will be the clerks or interns, you will be having that chance to be the first to see patients. Okay, so you have to be the one to first to identify if a patient is hypertensive or not. So you should know how to define all these hypertensive complications. Okay, you also have to know what is the normal blood pressure. Okay, what to note or not to note. When will you monitor again? How many times would you monitor the patient to conclude that she is already having hypertensive complications. And last is your multidisciplinary management. We would be needing a lot of our colleagues in the medical field, your internal medicine, internist. Okay, we also have to alert our pediatricians when we will deliver a small baby or a preterm baby. You will be needing your anesthesiologist, especially when you will do a cesarean section, or sometimes we will have to give anesthesia while doing our assisted vaginal deliveries. Okay? And then, yes, so you have to refer them sometimes for counseling. Okay? To other specialties as needed. Okay, so example, there's also postpartum psychosis, okay, or seizure with CVA. You can also refer them to your neurologist, and then if they have cardiac problems, to a cardiologist, etc., etc. So other drugs in preeclampsia, okay, so heparin is said to be not recommended for use in the recurrence of preeclampsia. So we have also discussed this in your consumptive coagulopathy lecture, why we don't use heparin. And so there are only times when we can use heparin as a treatment. Next is we could give calcium. It is said to decrease also blood pressure. Antioxidants are really not recommended, okay? But they could take multivitamins. Okay, so magnesium, although there's insufficient evidence, okay, there are already magnesium tablets in the market, okay, but still, if yung magnesium can be used when there's already your seizure or eclampsia. Diuretics, we don't give diuretics, especially in pregnancy. They have adverse effects of your baby having oligohydramnios, so we do not really give that. Limit salt intake. Okay, we have to uh, give them counseling on how to uh, monitor or limit salt intake, and not only the salt per se, but those with high preservatives of salitre, like your longanisa, like the common food like your tocino, where they put salitre as a preservative. Okay, even though if it's not salty, but still it is high in sodium, it could still cause hypertension. Fish oil is said to have no really significant evidence. So some would recommend garlic, okay? But I think the pregnant woman would do away uh, with the garlic smell. They wouldn't like that. Rest, okay, or exercise properly with the exercise for the pregnant, the scientists. You can follow that a little bit of exercise on using the upper body, not the aerobic type of exercises. Okay, progesterone. Okay, there's really no evidence, but it can control your preterm labor. Nitric oxide is not even used. So, but nowadays what is not mentioned here is the use of aspirin. We can already give high dose aspirin at around 11 weeks age of gestation, especially those who we believe would develop preeclampsia in the future. Okay, like example, elderly primigravida, okay, or those having chronic hypertension, we could already start giving aspirin. Others would recommend 150 milligrams a day of aspirin starting on the 11th week of gestation. Okay, so this could prevent uh, patient to have preeclampsia. So what is really the treatment of hypertension in pregnancy? Okay, so we all know that especially if the placenta is still there, okay, the baby is still there, that hypertension will not subside, okay, really. So the real treatment is delivering of the baby. But again, you have to consider what a lot of things, like the age of gestation of the baby, okay, should not be preterm, or if it's more than 34 weeks, then we could deliver. However, you again have to give your steroids to prepare the lungs of the baby, okay, and prepare them with proper nutrition. And also, you have to inform your colleagues, okay, and the NICU should be properly equipped with an incubator if needed. If you will be needing surfactants, okay, you have to inform your pediatrician so that you can be ready as a team. So, deliver the baby. That's the only solution there, okay, to solve the problem. So again, in the indications for delivery, maternal, you have a recurrent severe hypertension, recurrent symptoms of severe preeclampsia, progressive renal insufficiency, persistent thrombocytopenia or HELP syndrome, presence of pulmonary edema, eclampsia, depending on the age of gestation. Okay, and if it's a recurring eclampsia, uh, might as well do cesarean section. Suspected abruptio placenta and progressive labor or rupture of membranes, especially if it's a very prolonged rupture of membranes already, then might as well deliver it. For the fetus, gestational age of 34 weeks, no reason to prolong pregnancy with preeclampsia severe more than 34 weeks, so long as you give your steroids. If there's severe fetal growth restriction, less than 5th week by ultrasound, you have to do CS. Persistent oligohydramnios with a maximum vertical pocket less than 2 centimeters. Biophysical score of 4 or less in 2 occasions, 6 hours apart, with your reverse and diastolic flow on your umbilical arteries. Okay. Recurrent variable or late decelerations during your non-stress test. Okay. Of course, fetal death we have already to deliver. Postpartum, we have to monitor patients until 12 weeks postpartum. You have to do BP monitoring at home. Okay, so there are a lot of electronic blood pressure monitors nowadays available in Shopee and Lazada, but still if they would have the manual sphygmomanometer and they have someone to monitor them, it is better to use that. Okay. Otherwise, if they could afford to buy an equipment for themselves, also then do so. You have to advise them to get their blood pressures. Then you have again to instruct your patients to continue their medications postpartum, and then you have to explain to them until when eclampsia could occur post-delivery. So as I've told you, we even have an 11-week postpartum who still develop eclampsia in the past. So please monitor patients who are really hypertensive and do not discontinue their medications. Even if after 2 days after delivery, you noted that there's normalization of your BP, do not be complacent. They might come back after 3 or 5 days. They're already in coma because they have CVA or cardiovascular accident at home. So maintain them with antihypertensive medications. So do you have any question up to this time before I proceed to the next lecture? Anybody?
I think there's no questions.
Wala ba? Okay, so please don't forget to assign your those who just came late, please sign in with the attendance sheet. Okay, I would like to apologize because I am with my daughter a while ago, and it's hard to manage the Google. Because you cannot see yourself or what is in the background. Okay, I'll just look at my other slide. You could ask your questions in the chat box, okay, if you're ashamed to ask. Do you see my slides now?
Yes po, Doc.
Okay, so still high-risk pregnancy, my topic. Okay, among the high-risk, so di ba sa akin ang high-risk, even the word works, I handle your high-risk pregnancies. Okay, so we have your multi-fetal pregnancy next. Okay. So the objectives of this lecture is for you to know the incidence, etiology, and also risk factors of multiple gestation, and to be able to differentiate the placentation in multiple gestations, and to be able to discuss simple diagnostic modalities in diagnosis of multiple gestation and also management of its complications. Okay? During your ward works, I don't know if I have handled all of your group. Okay, I was able to send uh, the how to identify high risk pregnancies. Okay, so that will be a great help. This the hypertensive lecture and this one is just part of that. We need to expound more on that. Okay, but it will help you especially if you're having your history taking, and even if you will go to your clinical community medicine, that is a very big help for you. That is a lecture I give for midwives in if I happen to have the opportunity to lecture for midwives in the RHU or in the provincial office if they give us a chance. Then I lecture the how to identify the high risk pregnancy is very important. Even you clinicians later, clerk interns, or as general practitioners must basically know how to identify a low risk and a high risk pregnancy so as you know how to refer and when to manage them well. Okay. So because we obstetricians, we will be really needing the help of our other colleagues, okay? Because sometimes we have patients, ano na, they're already very much morbid, or even we meet patients who are already dead. Okay? That is what we don't like. We want to catch them at the early stage, and you will be a big help for us. So incidence and epidemiology for your multiple pregnancy or twin pregnancy, it occurs in 1 to 3% of all pregnancies. Yun nga pala, in your history, what you commonly forget in your family history is twinning in the family. So do not forget, you ask if there are twins in the family because it will help you diagnose your case, okay? Especially if they have twins in the family. So it is responsible for 10% of perinatal mortality, morbidity, and neurodevelopment problems. So in developed countries, it is increased from 1 in 100 to 1 in 60 to 70 deliveries. So 40% increase in twinning rate, okay? 3 to 4 increase in higher or order multiple births. Why in developed countries? Because they are already having your in vitro fertilization. Okay, they are more advanced in your in vitro pregnancies. Okay, having petri dish using diseases. So this is due to an expanded use of fertility treatments and or older maternal age. So increased rate, we have natural incidence, okay, low in Asians, high in blacks. So with the age, you have increased levels of your follicle stimulating hormone in older ages. Kaya it's more common in the older age, okay, with the risk of dizygotic twins. For parity, you have increase in zygotic twins. Okay, so the more pregnancies you have, gravida 9, gravida 10, the more chances that they will have twin pregnancy. So family history, gene mapping, they believe that there's a specific gene mutation expressed by oocytes. So dizygotic twinning has primarily maternal genetic component, but can also be inherited from both parents. Okay? So assisted reproductive technologies, dizygotic pregnancies are more in cases with ovulating agents and also in vitro fertilizations. Multifetal gestation secondary to assisted reproductive techniques in developed countries in more than 50%. Okay, so we have your classification of twins based on zygosity. I made a table so that it's easier. You have the monozygotic and the dizygotic twins. So for the number of fertilized ova in the monozygotic, okay, fertilization and subsequent division of one ova only, okay, while dizygotic, it comes from separate ovum. So genetic characteristic, they're identical unless after the division there was a spontaneous mutation which could cause fetal anomalies. the genetic characteristic of dizygotic twins are different from one another. Okay? Chorionicity and amnionicity, the timing of the fertilized ovum division determines the chorionicity and amnionicity. So while you're dizygotic, it always separate chorion and an amnion. So that's what we call dichorionic and diamnionic. They have separate placentas and separate bag of water. For the zygosity, dizygotic, you have your paternal twins. From ovulation and fertilization of two oocytes, which almost results in dichorionic placentation. In the absence of assisted reproductive technique, they are more common than monozygotic twins. Okay? And environmental factors plays a role in this condition. Strictly, they are not twins because they are from two ova. Okay? So they come from two separate ova. So factors influencing dizygotic twins, the use of fertility or stimulating drugs, maternal age, 15 to 35 years old. They are more common in the black race or in the geographic areas, more in blacks. Parity, more in the multiparous women. Family history, present, and maternal weight and height. So identical twins, in monozygotic twins, there are your identical twins. Usually, not identical due to possibility of not having an equal sharing of protoplasmic material. Technically, there is no 100% DNA which is the same. Okay, even their fingerprints in twins could be different. So ovulation and fertilization of a single oocyte with subsequent division of the zygote. Placentation might be dichorionic or monochorionic. It may be discordant for genetic mutations as a result of postzygotic mutation, and they may have same genetic disease with variable expression. So genesis of monozygotic twins. So when cleavage occurs at day 3, they are diamnionic, dichorionic. If the cleavage occurs at day 3 to 8, it ends up to be diamnionic, monochorionic, only one placenta, two bags. For day 8 to 13, they become monochorionic, monoamnionic. They only have one placenta and one bag. For day 13, when the cleavage is more than day 13, they become conjoined twins. So this is your example of your placentation. You could see your monozygotic or dizygotic. Okay. When you say dizygotic, you have two placentas there. These are your placenta here. And two amnion, the darker part, okay, the water part. Okay. And then you have here the fused placenta. However, they still have two chorions and two amnions covering, and the bag of water is 2. Here, your monozygotic, you have a single placenta, one chorion, and two amnions. So here you see one single placenta. And this one single placenta with also one amnion. So one placenta, there is no membrane in between. So they share a single cavity there. Okay? Clearer, this one. So again, as I mentioned, 0 to 3 days, cleavage, your 0 to 3 days, 4 to 8 days, and your 8 to 13 days, okay, mono. But more than 13 days, you will end up having conjoined twins. So diagnosis of multiple fetuses, you depend on history and clinical examination. There could be family history of twins, advanced maternal age, high parity, large maternal size, or your fundic height is larger than expected age of gestation, the size, ovulation or induction or assisted reproductive techniques. For physical examination, as I mentioned, large fundal height, multiple fetal heartbeats as early as 18 to 20 weeks. Again, it is confirmed by sonography or ultrasound. Other diagnostic aids which we could request, but we don't usually do x-ray, right? Radiologic examination in high order multifetal gestation, We could also use MRI to delineate complication in monochorionic twins or other biochemical tests. So ultrasound examination before the 10 weeks age of gestation, you have to observe for the number of gestational sacs present, the number of amniotic sacs within the chorionic cavity, and also the number of yolk sacs. Especially if you have two or more gestational sac, yolk sac, then you highly suspect for a multiple gestation. After 10 weeks, you have to note for an intertwin membrane. Note also for the fetal genitalia. If it's a boy and a girl, then most probably it is dizygotic. Placental number, okay, chorionic peak signs, and membrane characteristic, whether it is thin or thick. For dizygotic teens, they have separate placental sites, opposite sex fetuses, a twin peak or lambda sign, and there is a thick dividing membrane, or more than 3 layers, so it is more than 2 millimeters in thickness. Okay? For monozygotic twins, you could have single placental site, same-sex fetuses, a thin dividing membrane, okay? There's less than 2 millimeter thickness, okay? And a T sign or an empty lambda sign. Okay? So what is the pregnancy outcome? Abortion is increased 3 times. You could have lower birth weight, higher rate of respiratory distress syndrome. You could have admissions to the NICU and poor neurological outcomes, which include the following: cerebral palsy, stillbirth, neonatal death. So for preterm birth, there is reason for increased morbidity and mortality, which is the most common complication of twin gestation, preterm delivery. So prolonged pregnancy, increase in stillbirths beyond 39 weeks age of gestation. So 40 weeks is already considered post-term in a twin pregnancy. So long-term infant development, you could have visual impairment and difference in the anthropometrics and also in intelligence. So again, as I've mentioned, fetal complication, preterm delivery is the most common complication. With a mean gestational age at delivery, for twins, it's 35 weeks. For triplets, it's 32 weeks. And for quadruplets, at 29 weeks. There could also be spontaneous pregnancy loss or abortion or miscarriage, chromosomal and congenital anomalies, fetal growth restriction or discordant growth, a single intrauterine fetal demise, and specific monochorionic gestation complications like your twin-to-twin transfusion syndrome, a cardiac twin, and conjoined twins. So maternal complications of your multifetal gestation, we have hyperemesis gravidarum. Okay, especially if your patient in the first trimester is severely vomiting, it's either you suspect for twin pregnancy or a molar pregnancy. Preeclampsia, okay, highly possible to develop preeclampsia. Placental abruption, preterm labor, preterm premature or pre-labor rupture of membranes, gestational diabetes mellitus, and postpartum hemorrhage. So screening and diagnosis, how will we do that? Again, let's see, it's clinical history and physical examination is number 1. So you have to have a high index of suspicion with beta HCG also to be requested and a transvaginal ultrasound. So for ultrasonography, it is the most reliable and accessible and safest method for diagnosing multifetal gestation, and it can establish a fetal number, estimate the gestational age, and also determine the amnionicity and chorionicity of the twins. So we go to malformations. One, defect resulting from twinning itself. So some consider it as a teratogenic effect. So example, conjoined twins, a cardiac anomaly, neural tube defects, presence of holoprosencephaly, or sirenomelia, or the mermaid syndrome. Next is your defect resulting from vascular interchange between monochorionic twins. So there could be reverse flow with acardia, intravascular coagulation when one twin dies in utero, which can lead to microcephaly, hydranencephaly, intestinal atresia, aplasia cutis, or limb amputations. Okay. There could also be defects from fetal crowding, okay, like your talipes echinovarus or the clubfoot, or a congenital hip dislocation. For monoamnionic twins, there could be this is a problematic type of twin. So if we have this monoamnionic monochorionic type, we usually do cesarean section due to unpredictable fetal death. There's also possibility of having cord entanglement. So management, 1 hour fetal monitoring daily from 2 to 26 to 28 weeks age of gestation. We administer steroids and we do cesarean section at 34 weeks when fetal condition is reassuring and with completed steroids. Monozygotic twins, it can be symmetrical, separate, or conjoined. Okay, they could be also be asymmetrical, external, like your acardial twin, or parasitic twin, and there could also be internal fetus in feto or feto in feto. Okay, complications. A baby with a fetus inside the baby. So conjoined twins, they are Siamese twins. The parapagos is the most common type of conjoined twinning. Incidence 1 in 60,000 deliveries. Surgical separation can be done if essential organs are not shared, and dystocia is common, so usually we do cesarean section. Viable conjoined twins must be delivered CS. MRI can help in determining anatomic information. So the picture, types of conjoined twins, you have the ventral twinning and the dorsal twinnings here. So you have your rostral, your omphalopagos, they're connected at the area of the umbilicus. Thoracopagus at the chest area, cephalopagus at the head area. So for the caudal type, there's connection at the hip area, your ischiopagus. For the lateral, we could have your parapagus diprosopus, or 2 heads, 1 body. Your parapagus dicephalus, again, 2 heads. For the dorsal type, you have your craniopagus, connection at the head, brachypagus, and the pyopagus type. So we go next to the cardiac twin. Okay, you will hear this. So this is just the other twin which did not develop well into a normal human, okay, form. Okay, so I've seen one. It's just like a ball with a hair or with some protrusions there, a very small limb with a small connected umbilical cord, okay, where it derives its nutrition. It's a little bit also heavy. It has bony parts. It has a fleshy part and a bony part, but does not have any eye, no nose, no major parts which can be identified. So this occur rare, 1 in 35,000 births, 1% among monochorionic twins, also known as your twin reverse arterial perfusion sequence, serious complications of monochorionic multifetal gestation. So the fetus is lacking a head and normally develops a heart. But I think the one we saw is a head, not a heart. So the fetus can survive while in utero due to the placental anastomosis, shunting blood flow, or the pump or normal twin. So normal form donor, the donor is normal with features of heart failure, and recipient twin with no heart, or that's the cardiac. So that is what you call the recipient twin, and no other structures. So caused by a large artery to artery shunt and accompanied by a venous to venous shunt. So next complication, you have your twin to twin transfusion syndrome, or your TTTS. It results from unidirectional flow through arteriovenous anastomosis. It occurs in your monochorionic placentas. The donor twin is anemic and the growth is restricted and the donor is pale. while the recipient is polycythemic and may develop circulatory overload manifested as hydrops or pretoric type, may have occlusive thrombosis in the neonatal period, and you could also see hyperbilirubinemia or yellowing of the skin, kernicterus due to polycythemia. So how would you diagnose it? There is weight discordance or differences in weight, hemoglobin differences also, and they can use the Quintero staging by ultrasound, where the stage 1 is a discordant amniotic fluid volume, but there's still urine and available within the donor's twin bladder, while the stage 2, there is no urine noticeable or visible. Stage 3, you have stage 2 plus an abnormal Doppler studies of your umbilical artery, ductus venosus, or your umbilical vein. Stage 4, there could be ascites or frank hydrops in either the twin, and stage 5 already if there is already fetal demise. Okay, so what is a discordant twin? There is size inequality of the fetuses. Okay? So the larger twin is always the index or the basis. Okay? There is a sign of pathological growth restriction in one fetus. So early dysorgancy develops, it is more serious. So pathology, you have monochorionic, placental vascular anastomosis, hemodynamic imbalance between the twins, reduced pressure and perfusion of donor twin causing diminished placental and fetal growth. So for dichorionic, you have various causes. You have dizygotic fetuses in which there is different genetic potential, especially opposite genders. So one of the placenta may have a suboptimal implantation site. Okay? So we have to compute again for the weight difference. Okay? So the weight of the heavier twin minus the weight of the lighter twin over the weight of the heavier twin. That would show your percentage. Okay, so the larger baby minus smaller baby weight over the weight of the larger baby, you get the percentage. So 25 to 30% weight discordancy, there is already an adverse outcome. For abdominal circumference also, you could also get the difference between when you measure the abdominal circumference through your ultrasound. A difference of 20 millimeters would again show discordancy among the twins. So antepartum management of twins, what do? We have to reduce perinatal mortality and morbidity. Okay? So we have to prevent preterm delivery as much as possible. Okay? So we have delivery of markedly preterm be prevented. Okay, as I've mentioned, okay, at least 35 weeks, 35 to 36 weeks pag twins, di ba? Fetal growth restriction can be identified and afflicted by be delivered before they become moribund. Okay? So we have to do a serial growth monitoring to note for your fetal growth restriction. Okay, so in your growth chart monitoring, you could see a chart. Okay, if it is in within the less than 5 percentile mark, then the baby is already severely growth restricted. So we have to deliver already the baby. Fetal trauma during labor and delivery must be avoided. Okay, and there should be an expert neonatal care. So if you happen to diagnose a mother with twins or triplets, okay, be sure to refer them to a center where there is an adequate neonatal care or available incubators, okay? Especially for the severely preterm babies. So a low dose aspirin has been recommended started at 12 to 28 weeks. Okay? As I mentioned a while ago, not only it will prevent preeclampsia, it also would provide a good blood flow to the blood vessels in the placental blood flow. So prenatal care and surveillance. So prenatal care should be individualized with consideration of the following. So monoamniotic twins are at risk for cord entanglement and conjoint weaning. Okay? So you have to check very well, okay, with the use of your Doppler velocity studies and schedule them early. The earliest time for scheduling monoamniotic twins, okay, early so as not to produce or not one twin to be become to end up having fetal death. Okay, so prevent cord entanglement. Monochorionic twins are at risk for complications such as your TTTS, TRAP syndrome, and twin anemia polycythemia sequence. Okay? Again, this one is your difference in your hemoglobin levels, growth restriction, congenital anomalies, and spontaneous pregnancy loss. So there should also be additional calories and supplementation. We know that the calorie requirement and supplementation needed by a mother with twin pregnancy is higher than the regular, okay, normal singleton pregnancy. Can vaginal delivery be done? Yes. If the patient or the baby is in cephalic presentation or cephalic first with a non-cephalic presentation, so long as the operator or the obstetrician who will deliver knows how to do a total breech extraction and a breech delivery of the second twin. Then breech to breech, unless with the following, unusually large fetus, we cannot do that. Fetus sufficiently small, and there's cord prolapse, you do your cesarean section. Okay, so breech to breech, unless the you have the criteria, unless it's okay. Okay, but most probably if you have breech there or footling breech, you do your CS already. So delivery of second twin, you have to do your internal podalic version, locate the foot, fetal foot, then convert the transverse lie into a breech presentation. Then you have to know how to deliver the baby by breech delivery. Okay, so we go to triplets or higher order pregnancy. All, especially triplets or above, okay, no questions, deliver by CS. So you already know. If you have a triplet patient, you don't allow them to go into vaginal delivery. It's always by cesarean section. Because of the increased incidence of a cord prolapse and reduced placental perfusion and hemorrhage from separating placentas. Okay. So, selective reduction and selective termination is not allowed in the Philippines. Okay, I really can't talk or tell about in other countries. Okay, especially if they discover you have 6 tuplets, I don't know if they allow reduction. But here in the Philippines, definitely we still do not allow selective reduction and selective termination of a twin. Okay, that's the end of my slide. Then, do you have any questions? Am I too fast or not? Going back to you. Okay. Any question with the two high-risk type of pregnancies? Hypertension and multifetal pregnancy. I did not discuss regarding findings of Doppler velocimetry. How would you interpret? How would you read it? Because it's really not yet in your level. It's for those going already to subspecialty or subspecialty. It's just suffice to know that when you see a Doppler velocimetry study and you see that there is absent or reverse, the word absent there or reverse, okay, velocimetry findings, that is already a sign that your baby is not doing well inside, then you already have to do a cesarean section immediately. Or if they can be delivered immediately, like if there's an imminent delivery, if we say imminent delivery, cervix fully dilated, the head is there, then deliver them with assisted vaginal delivery. And when we say assisted vaginal delivery, you can deliver them via using your forceps delivery or your vacuum extraction. So I hope when you go into clerkship, you would be able to witness how the residents or your consultants would do a vacuum extraction or a forceps delivery. Although in your OB clinics, I think your OSCE oral exam, they will allow you to see, I think, how it is done with the mannequin, how to do a forceps or vacuum delivery. Okay. So any question, class? You are 99. Anybody absent? Did everyone sign again, I'll fix it again, your attendance sheet. After I close the room, I usually close the attendance sheet already. So any question? None? How many groups are you in the ward works?
Doc, I believe 10 groups po.
10. So I was not able to handle one group. It's your shifting exam next week, is it? Shifting exam. Okay. Anyway, you just share to the group 10 who I was not able to handle the one I sent you in the ward works regarding high-risk pregnancy and your SOAP, okay, so that they could also learn a little bit from me. Okay. So if there's no question, please get your documentation for today.
Okay na po, Doc.
Okay na po. Okay, so this is my last lecture with you. Nice meeting you all again, and I hope you study well. Okay, see you in the exams. Still my lecture. Usually I just give from the lecture. Okay, read a little bit from read your book. Still your book. They still require you to read your Williams, okay, 25th edition. Okay, so good night. Thank you. Bye-bye.
Thank you po, Doc.